Welcome to another edition of Aesthetic Revolution, the podcast. I'm Dr. Zimmerman, your host. Staci Taylor Zimmerman, our hostess with the mostest, keeps me from diving down the rabbit holes as we discuss aesthetic topics from forehead to feet with some extra attention in between, since that seems to get up a lot of attention in the office. Today's discussion, though, we thought we'd talk about an oldie but a goodie, a gold standard, if you will, and all the variations of elements that have come off of it. So laser skin resurfacing. And we're talking primarily about the face, sometimes the face, neck, chest, backs of the hands, but people are coming in looking for skin rejuvenation. And certainly carbon dioxide laser or CO2 laser is something that's been around since the late 80s and technically before then, but it's been used on skin for aesthetic purposes starting from the mid to late 80s. And that was a continuous wave CO2 laser. So basically, when it was on, it was like a James Bond movie. When it was on, and you were burning the top layers of skin. The chromophore or target for carbon dioxide laser is, of course, water. So anything that contains water. So I use the CO2 laser for doing surgery, for doing upper lid blepharoplasties, transconjunctival lower lid blepharoplasties, canthopexy, rhinophyma, and skin resurfacing of all kinds, but particularly the face, since the face recovers so well because there's so many pilosebaceous units. Those are little tiny hair follicles with oil glands at the base. And so the furry face recovers elegantly and excellently from energy modalities if they're used correctly and to the right depth, whereas the neck, the décolleté, and other areas of the body have smaller amounts of little hairs, and there are islands of improvement, but there may be scar tissue formed in between, so we have to be very careful how we utilize these energies. Mm-hmm. Sometime in the mid-90s, and we were using the CO2 laser for doing all kinds of primary care procedures. So excision of lipomas and lumps and bumps and removing superficial basal cell carcinomas and elevated seborrheic keratoses and all kinds of things, ingrown toenails, laser no scalpel vasectomies, laser hemorrhoidectomies. We did all kinds of things with laser in the outpatient arena because it works well. And it creates a nearly bloodless field with a non-touch technique that allows you to very carefully sculpt the tissue under good vision. So I always wear magnification and have good lighting around. Mm-hmm. And, we have to protect the people or items within the nominal hazard zone. So we have to make sure that the eyes of the patient that we're working with are fully protected, that we don't have any laser energy hit the cornea or be transmitted through the cornea or anything like that. It's an entirely different kind of procedure because we don't have all the paper drapes. Paper is flammable. So when we're using CO2 laser or some of the other lasers we're talking about, we minimize those. In fact, we used to almost wrap people with aluminum foil, but it had to be crinkled so that it couldn't mirror and bounce the laser somewhere else. Everybody had to wear eye protection. Everybody has to be aware that if they're working within the nominal hazard zone, that laser could, affect them. And certainly a smoke evacuator is critical because the laser instantaneously vaporizes whatever it touches, a tissue in particular. And there could be viral particles, there could be some carcinogenic particles, there could be all kinds of noxious things that could go into the air and be breathed in. So we make sure that we have a very strong smoke evacuator. We're wearing special filtration masks when we do laser surgery, things that we take for granted now, but John Q. Public probably doesn't know a lot about. Mm-hmm. And then historically, in the mid to later 90s, there was a revelation in lasers where we went from a continuous wave laser to a super pulse or an ultra pulse laser. So very high energies, but short trains of energies with pauses in between, duty cycles that were ultra short. So you could use that energy to very quickly make an imprint on our chromophore without putting as much energy into the surrounding tissue. So it decreased the thermal zone of injury around where a laser beam was, and we could use smaller spot sizes with these short pulsed laser beams. It's so short that it's invisible to the human eye. And this wavelength is invisible to the human eye. So sometimes you had to either have a red helium neon pointer beam, or you just knew exactly where you were using it from the result that you saw, but it's a non-touch technique. But we use these lasers for resurfacing skin elegantly. And we got such nice results. It replaced some upper neck, lower facelifts for quite a while. And whether a person just had a little bit of wear and tear and laxity and pigmented lesions and things that could be improved by allowing the surface to be removed and start fresh again, or they came in looking like a cross between a Shar-Pei and a California raisin. And that's really where these energy modalities excel, depended on what you used. But not everybody was a candidate for a fully ablative super pulse or ultra pulse CO2 laser. Some people needed a kinder, gentler modality. And
so real quick, I want to just stop you. So back in those days, you were taking the epidermis.
The epidermis down into the papillary dermis, and hopefully not into the reticular dermis, because that causes scarring.
Without any islands of tissue left behind. So you were taking all of the tissue. This is why the downtime was 3 months of oozing. And so a lot of people still remember that, though.
Maybe 3 to 4 weeks of relative time till they reepithelialize. But
I think what people see on TV or when they go online, they see the stories of 3 months downtime. And what that is a much more aggressive when you're doing a fully ablative CO2 versus now what we tend to do more is a fractionated. So the differences between the old time, versus fractionated, which is what most of us do now. So I just want to differentiate between that so that people don't look online and see that 3 months, of oozing. And back when it used to be the movie stars would only do it and they'd be wrapped all up. And, that's kind of what
it was like the old phenol peels or cotton oil peels.
Right. So we do it differently now, but back then that's what we were doing. We were taking all of the tissue off, and now we leave islands of healthy skin behind, and that's what's called fractionated. So
instead of having a beam that is a solid beam of energy with an equal amount of energy both from the middle all the way out to the periphery, without a Gaussian distribution of energy where it becomes less towards the periphery, equal top hat amount of energy going down, so you have an even amount. Now we have little micro pinpoints, whether it's bouncing around or whether it's a scan, little tiny micro pinpoints, much smaller spot sizes with islands of untreated tissue in between, that the skin can restore itself and reepithelialize in days now. Now, that said, when the epidermis, the 8 to 12 layers of skin cells of epidermis peel away, we all are pink underneath. And so the pinkness that you see, irregardless of your normal skin type or skin tone, is a normal part of healing until the epidermis, which takes 30 to 40 days to repopulate a layer, becomes thickened up till it's 4, 6, 8, 10, 12 skin cells thick. You see the pink that's underneath. And it's a nice healthy pink, and it can be covered with a tinted sunblock, a physical block, not a chemical block is preferable, but it's something that people see. And, certainly with the CO2, one of the issues we had, depending on the skin type, is that as you moved from the parts of the face that had many pilosebaceous units to less pilosebaceous units, people looked great initially. You had to work hard to feather out the edges and not have a line of demarcation that showed. But where they transitioned from more to less pilosebaceous units, if they got a skin injury down the road, 2, 3, 4 years later, they got a bad sunburn, it could turn off the pigment cells. And so they would have an unpredictable line of demarcation of hypopigmentation, loss of pigment, that could turn up years after CO2 resurfacing, when we used to do fully ablative CO2 resurfacing.
So you're talking about the line at the jawline, or right underneath the jawline,
that we hoped would stay
the
there
to the neck.
Yeah, but when we ironed the face smooth, we got such contraction of the tissue that a line under here might really work its way up onto the side of the face. And so we had to be we learned quickly to be careful and to feather out the edges and go a little bit further so we could account for that migration and not have a visible line of demarcation. But sometimes when you would resurface the face and there was no good place to stop, because the face went straight onto the neck, or the neck went down onto the décolleté, you had to figure out strategically where you would stop, or add a different modality to this tissue that wouldn't take the high energies and would have too difficult a time healing or healing nicely. So then we integrated chemical peels back into the neck and the chest, or now we do radio frequency, or now we do fractional, and we just turn the parameters down. And we can certainly do face, neck, and chest with attention to around the mouth, the muzzle I call it, and around the eyes. So we can clean that up and shrink wrap that and tighten it and iron it and smooth it and take away some of the pigmented lesions and even some of the superficial vascular lesions. So, but I digress. CO2, which is 10,600 nanometers, so it's far infrared, was then replaced or transitioned to for a while with erbium YAG lasers. So erbium, yttrium aluminum garnet lasers are a 2940 wavelength, whose energy is also absorbed by water, but much more absorbed by water than CO2. So the erbium laser didn't go as deep into the tissue because the energy was all absorbed by the water-containing cells. The CO2 went deeper into the tissue. The erbium laser's energy didn't cause as much heat, so you didn't have as much hemostasis trying to use it for surgical things like blepharoplasties and facelifts and stuff like that. So CO2 still was the gold standard for many of us, but erbium was a kinder, gentler modality for more superficial resurfacing of patients that didn't have as much solar damage, as much UV solar elastosis and stuff. And along the way, there were certainly attempts to put the two of them together and have both wavelengths firing at the same time, or do one and then the other, all the combinations in between. And, but these days we have that, and we have other ways of doing it. Now we have energies like plasma. Plasma is a fourth state of energy, like the sun. And we're able to create a plasma field where we vaporize the upper layers of tissue, primarily the epidermis, but the superficial papillary dermis. And we can literally paint from the forehead to under the mandible, either with a series of pulses or very carefully painting with a minimal overlap, with a helium plasma or a nitrogen plasma. I happen to prefer the helium plasma at this point. I think that's the current state of the art. And we can very carefully shrink wrap the tissue, but we leave the eschar, that white cooked tissue. We don't take that off anymore because that mechanical dermabrasion we think was a cause of some of the issues, the hypopigmentation, the prolonged redness, stuff like that. So we leave that intact as a natural dressing. And whether you make one pass or two pass or three pass, depending on what your pathology is you're treating and your technology, you can literally paint the whole area. And then you can go to a pulsed format where you can treat the neck and or the décolleté in places like that.
So this is not fractionated, this is fully ablative. So now we've gone from fully ablative CO2 to fractionated CO2 to now we have technologies that are, again, fully ablative.
Either pulsed,
yes,
pulsed. Or continuous. And depending on how you use the swath, you can get a pretty fully ablative, so it's sort of an in-between. To me, that's the new gold standard.
Right.
Is that by leaving the eschar intact, you create a biological dressing that you can saturate with the patient's own PRP, platelet-rich plasma, maybe some exosomes, maybe some rejuvenative factors. And as that sheds over the next 3 to 5 days, they're reepithelializing at 7 to 10 days, and they've got brand new baby butt skin underneath. So
the downtime
it's pretty
is
cool.
A bit longer, no doubt, than a fractionated CO2, but the result is a lot better, I would say. When
predictable,
of course, fractionated versus non-fractionated, fully ablative is always going to give you a better result. You just have more downtime. So if you're willing to do the downtime, the fully ablative is a better option, but not everybody wants to do that. So
if you have the right pathology and the right skin type. So,
right. Well,
we've certainly learned over the years that in order to minimize pigmentary issues and healing issues, we're primarily treating Fitzpatrick's 1, 2, and 3, the occasional 4, depending on what their ethnicity is, who their grandparents were, so to speak. Certainly our Latin heritages that have the thicker, oilier skin respond beautifully to these wavelengths. Some of the Asian heritages, that the skin and pigmentation is a little more challenging to get it to heal smoothly and beautifully and equally, and not pigment in a weird way, or hypopigment. We're more careful with those. And we'll use other things like radiofrequency microneedling or ultrasound as a non-ablative device. We have ways of getting around that. So lots of choices.
Yeah. So our darker skin types, we usually don't do the ablative or fractionated CO2 on, right, because of that.
That's where ultrasound is king, because right, it's colorblind. It doesn't care what color right, the skin type is. We don't want to leave
a line of demarcation. There's just a lot of issues that come when you have those darker skin types. So
yeah. So those are considerations that we think about. I like lasers, whether it's fully ablative, fractional, and plasma devices, because I have an enormous amount of control with these devices. I can take it down to a 0.8 millimeter spot with a CO2 laser, or I can use a scanner. I can do a lot of hand blending along the edges. My plasma field is somewhere between 4 and 6 millimeters wide, and I can come even with a perpendicular stripe. I can control my overlap so that I can get preferential vectoring lift and tightening along the lines of tension in the skin. So there's an artistic use for these tools that it's just like playing a musical instrument. Some of them fit better in your hand and allow you to do the artistic parts of the contraction and the tightening and ironing and smoothing on a face that others don't necessarily let you do. And we do a little mix and match when we need to, certainly, especially around the eyes and the mouth, recognizing that we can get some pigmentary issues, but we get the smoothing and the tightening without causing issues that other technologies don't let us do. So just so we're clear, this is not a plasma pen we're talking about. No. This is actually Renuvion and Neogen and some of the others now create a plasma field, which is a non-touch field where the radio frequency energy is generated and the entire epidermal surface down and is partially vaporized and dehydrated, and the papillary dermis, the next layer down that you want to perform microscopic damage to in order to get it to contract and to heal, very, very different from something you would touch with essentially a hot electrical wire. Right. Yeah. Just want to make sure, because if people hear plasma, and that's immediately might be where they're thinking. So I wanted to make sure. Yeah, and it's not the plasma we think about with blood. Blood separates into red blood cells and plasma when you spin it in a centrifuge. And that's a whole nother podcast where we talk about the things we do with platelet-rich plasma, platelet-poor plasma, and all the elements in plasma. So, that's something pretty different. So when a patient comes in and they want to talk about skin resurfacing, we decide whether we want to do superficial or mid-depth or quote-unquote full depth, well down into the papillary dermis and touching the reticular dermis, whether it's going to be ablative, non-ablative, fractional, all those things in between. We talk about the journey through the recovery and how long it takes them to do things. So let's talk a little bit about that recovery. When they first come in, if we're doing mid-depth or deeper, we're generally going to the operating room. We're doing some nice sedation. They're floating in their happy place and controlled and monitored the whole time. And then I tend to inflate the face with a little bit of tumescent anesthesia, just like I would for a facelift or liposculpting or something like that. So it gives me both a thermal dam where I can make sure my energy doesn't go too deep. It also cools the dermis so that when I'm putting energy from the top, it makes sure I don't go too high. It gives me just a little bit of extra cushion there, but it means they don't feel anything for hours and hours. And by the time we check in on them that evening, it feels like a little bit of a sunburn. And their face has had the PRP, the platelet-rich plasma, the exosomes, the rejuvenative factors installed, and they're ready to have their petrolatum, usually, occasionally Crisco, but petrolatum bandage applied so that they can go home. So Aquaphor is one that's commonly used. So many expensive dressings over the years that we've tried, and we've gone back to something as simple and inexpensive as Aquaphor. But if they have a petrolatum allergy or sensitivity, we can use the old-fashioned Crisco. So if you can make chocolate chip cookies, you can find some Crisco that doesn't have any smells, colorings, anything like that. Go in with a sterile tongue blade and use that to melt on your hands and apply, clean hands, and apply gently to the face. And then we're going to take them through the care afterwards, and that's something that you do a lot of.
What we have them do in the morning, that next morning, we'll have them put a mixture of water and white vinegar. And I like to use an old t-shirt, and have them cut it like a face mask. And they'll dip that into the cool vinegar water, and they'll soak their face for about 30 minutes. And that just helps to cut that Aquaphor off and cut that exudate so they can clean the skin off. Also feels really good when the face is kind of feeling kind of burny. It helps to kind of cool down the skin as well. And then we have them put another layer of Aquaphor on, and we have them do that 3 times a day. That's going to be for about 5 to 7 days, just depends on the healing, but it's kind of a tried and true method. We've tried to replace it, like you said, we've tried to find other things to do. People don't like smelling like a salad, but it really is the best thing we can do after CO2, because the white vinegar will keep you from growing a fungus or a bacteria on the skin. You're doing that 3 times a day, and that's really
or more.
Yeah.
And then they're jumping in the showers in between.
Right.
And eventually you put them on a very gentle cleanser, and once
the skin's kind of healed over a bit, and then we have them start with a gentle cleanser, and then slowly move them off the Aquaphor and onto a thick cream, and then of course always a sunscreen. But most people do very, very well if they stick to that regimen. If anyone deviates from that, then they could possibly have an issue. But we've been really lucky; we haven't had anyone. But we really sit down with them before they even have the treatment, give them the protocol, and make sure they have all of the things ready for them at home before they have the procedure done. So it makes it pretty simple to do.
Yeah. So a lot of education, a lot of keeping them under wing, bringing them into the office and teaching them how to apply the white vinegar soaks, and letting them know that if it does sting a little bit, they just need to dilute it out. It brings the pH down, like you say, to keep bacteria and fungus and things like that away. And they're on antibiotics, antifungals, antivirals if they're prone to cold sores, all that kind of stuff. And we're watching them very carefully to make sure that they stay out of trouble, because the time that they put in that first week pays back in huge amounts for the overall duration of action that they're going to have, and for the evenness of the skin tone and the texture and all those kinds of things. So we usually get them out of the thick goo and into a moisturizer by the time they're about a week, sometimes 10 days out. They've got some redness that can persist depending on whether they started out as Casper the Ghost or a little darker skin type. The redness persists until they build up enough layers of epidermal cells to mask the refraction of light off the underlying hemoglobin moieties, so that their skin doesn't look as red or have a bluish cast to it. And, by the time they're reepithelialized with their moisturizer, you've got them into a pigmented sunblock. So they're ready to get out and about by the time they're, 10 to 14 days out. And they may still be peeling and flaking because they're making brand new baby butt skin, and they're just exuberantly producing, new skin, and it's continuing to tighten and smooth and blend for up to a year. And then the results very often will last 2, 3, 4, occasionally 5, but certainly in the 3 to 4 year range. And with a little careful maintenance and home program, it can last much longer than that. And it can be repeated, or it can be modified. So a more fully ablative treatment with a plasma energy, or, a combination of deep and superficial resurfacing with fractional complemented by fully ablative around the eyes or mouth, maybe, in 2, 3, 4 years, may just be a more superficial resurfacing that's all fractional.
I'm always amazed at when you're doing it, you tend to do heavier around the mouth and the eyes, because many times that's what patients need. That's where they're seeing those fine lines and wrinkles, is around the eyes and around the mouth. It's amazing how much tissue tightening or how much you can get from a CO2. In just rejuvenating the skin to have it look so much better. I'm always just amazed at how well, people do and how the results are. And they say with CO2, 6 to 12 months, really at 1 year out, is when you're going to see the max results from a CO2. Which I think is amazing, because you just keep looking better and better, and people are just like, gosh, you just look great. They don't really know why, but you're a year out and you look the best at 1 year. So
and we complement, very conservative correction of volume, and we keep the dynamic wrinkles minimized so that as your new skin is healing, it doesn't learn the same old folds. So we're using your neuromodulators, your Botoxes and Xeamins and Dysports and such around the eyes and in the frown area, so you don't recreate the 11 or the 111s. You don't recreate the crow's feet as much. You don't recreate the horizontal fissures in the forehead. Those are all things that we can modify and, keep under control. So we turn that clock back and we slow the rate of progression of the clock coming forward again. So that's what makes skin resurfacing one of the most fun, most, improved, cosmetic things that we can offer in the office.
I feel like it's the one thing I've done that probably gave me the most bang for my buck. I mean, I'm redhead, freckled, and I had a lot of sun damage from, years and years of being in the sun and
being a beach bunny.
That's right. And when you did my CO2, I mean, I almost don't remember how pigmented my face was before.
Yep.
But boy, I was looking old with all those sunspots. I mean, they're little freckles that look youthful for so long, suddenly become big, and they all grow together and they become big, sunspots, not so attractive.
Yeah. So, and I've had full face erbium.
Yeah.
So, we all need our particular prescription for skin rejuvenation and maintenance. And got to walk the talk and talk the talk.
That's right.
So anyway, we've spent some time, talking about the different parts of the electromagnetic spectrum that we utilize for skin rejuvenation, particularly of the face, but we use these same technologies down onto the neck, chest, backs of hands, and other areas of the body. But the face is the big one that people come in asking about. So, we've talked about CO2, carbon dioxide. We've talked about erbium, which is erbium that's doped onto a yttrium aluminum garnet crystal, and their energy sources. We've talked about plasma energy, helium plasma, nitrogen plasma, fractional, pulsed, fully ablative, and all the variations in between, and a little bit about the recovery and the expectations and duration of action. So thanks for joining us for a fun podcast, Aesthetic Revolution, the podcast, talking a little bit about skin rejuvenation and resurfacing. And ask questions, like, look, listen, all that kind of stuff. We enjoy answering the questions and, sharing our knowledge and experience with you. And we'll look forward to seeing you again on another podcast in the near future. Thanks for listening.